Okay, good morning, everyone, and welcome to our second discussion in diagnosis. So we just started last week. And for those of you who don't know me, I'm Goutham. I'm the director of the Advanced Center, which is an ARC-funded center, whose aim is to improve diagnosis overall. Specifically, our center focuses on identifying best practices for common but serious medical problems. So last week we did a little bit of an overview of the center and its activities and staff and priorities. And this week we are actually going to tackle a clinical issue and a research issue that's very important and is actually the focus of one of our demonstration projects as well. So this morning our discussion is going to be with Dr. Kelsey Ufholz, who is a PhD behavioralist within the Department of Family Medicine, and is part of my research team and will be co-leading the demonstration project on unintentional weight loss with me over the next, I guess, 3 years or so. So with that, I think what we will do, the format for these discussions is largely informal. I'm going to discourage the use of PowerPoint presentations because I think that over the course of a day, many of us in academic medicine are exposed to quite a few of those. So it's going to be a very informal discussion. I'm going to ask Kelsey a series of questions, and at the very end, we will have a more open discussion and then talk also, and we'll open it up to questions as well. So Kelsey, thanks for agreeing to do this morning. So, we're talking about unintentional weight loss, and, the words I think are pretty clear as to what that means, but can you maybe give us a summary of what the actual definitions might be?
Of course, and thank you for the introduction. Unintentional weight loss, just broadly speaking, is when a patient loses a large amount of weight in a short period of time without an obvious explanation for it. So they don't have a medical diagnosis which would explain a sudden loss in body weight, and they're not doing anything such as dieting or exercising to try to lose weight on purpose. Because it's normal for weight to fluctuate, even over the course of the day, one of the big issues with unintentional weight loss is how much weight has to be lost within what time frame to actually be considered of clinical concern. And unfortunately, there's not a lot of clear and consistent guidance on what that should be.
Okay, so I'm thinking that if I have a patient that has lost a couple of pounds over the course of a few months, I wouldn't be too concerned. But I think what you're saying is if this is a substantial amount and the standards are quite variable, it can be a percentage, it can be a number of pounds or kilograms over variable time periods. No real consensus as to what the definition should be. We should be more concerned about it.
That's correct. And usually unintentional weight loss is looked at as a percentage of body weight because patients start with such variable body weights. So they don't look at absolute amounts, but a few common definitions that get thrown around might be 5% of a patient's total body weight within 6 months, or 10% within a year. I saw recently, sometimes the time periods are shorter, for example, 1 month, but there's a lot of variability within that.
Terrific. Okay. So, obviously this is something we ought to be concerned about. We have a really broad range of folks and clinicians and scientists on the call today. And I see, for example, Dr. Stephanie Teal, who's a chair of obstetrics and gynecology here at University Hospitals and Case Western. And, I'm saying if she saw a woman, for example, an older woman who had lost weight unintentionally, hi, Stephanie, unintentionally, a woman, let's say in her 60s or 70s, I would be terribly alarmed by that because I'm concerned about an underlying malignancy. So what are some of the causes that we ought to be concerned about?
Unintentional weight loss can be a symptom of a lot of different problems, some of which are not medical or medical adjacent. Like, for example, a patient might be food insecure and losing weight simply because they don't have access to the nutrition they need. It could be more of an indication of a psychological disturbance. For example, changes in body weight are associated with depression and, of course, eating disorders, though that's often less unintentional. And on the more medical side, it can be associated with quite a few, such as an uncontrolled infection, such as HIV, a gastrointestinal problem, such as celiac or Crohn's disease, and as you mentioned earlier, cancer, which is unfortunately one of the more common underlying causes of unintentional weight loss and one of the more severe ones.
Okay, thank you, Kelsey. So it's interesting. We mentioned malignancy as the most serious cause. So some of those other things you mentioned, an uncontrolled infection, depression, difficulty accessing food. I'm thinking about poor fitting dentures in an older patient, not to say this is exclusively happening in older patients, but they would be associated with other signs and symptoms. So can you tell us a little bit about malignancy and why it's such an important cause to consider?
Well, for one thing, malignancy and cancer is such an important thing to consider is because it's just so common. The two are really quite linked. Some of the results that I looked at say that cancer may be found to be the underlying cause of unintentional weight loss up to 36% of the time, which is, quite common. And unintentional weight loss may be a symptom that cancer patients often have when they're diagnosed. Up to a third of patients have unintentional weight loss upon diagnosis, and often that's the only symptom, which makes it an especially important early warning predictor. And one reason for this strong link between unintentional weight loss and cancer in general is it's associated with lots of different types of cancer. So ovarian cancer, lung cancer, prostate, non-Hodgkin's lymphoma, colorectal. So that's quite a strong link there.
So quite a spectrum. So what I guess I'm hearing you say is that this can be an early warning sign of cancer. And Dr. Jordan Winter and Jonathan Hugh are not on the call this morning, but this is one of his interests as well, that even though we've developed a lot of expensive and complicated screening tests and diagnostic tests for malignancy broadly, simply knowing someone's weight and if they've lost it, especially as they get older, may be a really inexpensive way to detect cancer. And as you said, it's often associated with no other symptoms. So, somebody who has depression, for example, is obviously going to have symptoms in addition to weight loss. So tell us, are we doing a good job of picking this up as far as physicians, clinicians broadly go? How are we doing?
Unfortunately, we're doing very, very poorly, especially given that body weight is a very simple measurement to take, and we often have body weight longitudinal data on a patient going back years. One of the more well-known articles on unintentional weight loss comes from Rob Alcara. He did a chart review of 170 patients and found that unintentional weight loss was only recognized about 40% of the time. And granted, his criteria was looking at a loss of 10% body weight that could be both voluntary and involuntary. Our research group recently did a pilot study trying to look at it a little bit more systematically using various definitions and trying to distinguish between unintentional weight loss and intentional weight loss, because obviously intentional weight loss is completely separate and not an issue, and found that clinicians generally do even worse than 40% recognition. It's more along the lines of 28%. So the vast majority of presentations of unintentional weight loss go unnoticed.
Yes, and that is a very serious concern. I can speak a little bit about why we are doing so poorly, and you know, the reasons, as Kelsey mentioned, we're doing a pilot study. It's not quite finished yet, but we're almost done with it, and this will set the stage for our larger demonstration project that Kelsey will give us a bit more detail about. But one of the reasons certainly is a lack of guidance. So the goals of our diagnostic center are to approach problems that are common, so not rare diseases, that are associated with both serious underlying conditions and more benign ones. Now, unintentional weight loss definitely falls into that category because it can be benign. It could be somebody who just happened to be traveling and had a decreased level of appetite, or relatively benign. In other words, they may have mild depression leading to unintentional weight loss, or it could be a serious underlying malignancy. And the third criterion for the types of problems we'll approach in this center is a high degree of variability in physician practices or clinician practices. This one definitely qualifies for it. There is very little guidance as to how to approach this problem. The only guidance we found, Kelsey and I found, were some review articles, which are authoritative, but are largely just based on the opinions of the authors rather than any sort of scientific evidence. So it's kind of the prototype of the problem for the UH Advanced Center in general. So let me talk a little bit about what we found in our pilot study in terms of physician practices, because it was quite fascinating. First of all, as Kelsey mentioned, it's about 28% recognition rate. We found that many patients were losing weight, and it was almost always intentional. So when you see in a chart note, we do careful reviews, you know, dieting and exercise, good job. We know that that's intentional weight loss. The unintentional weight loss seems to provoke a little bit of a panic in some of our physicians when it is recognized, but they are remarkably consistent in the tests and approaches that they order. Everybody seems to get a CBC, a TSH, and a complete metabolic profile. But nobody knows, are those useful or not? We did not look at the results and how they might influence, we haven't done this part yet, influence further evaluation. Some patients get imaging. So then after those 3 tests, there's a lot of variables. Some people are referred to specialists. A lot of patients, a lot of cases, after the 3 most common tests, the next most common thing to do is not to do anything, just to kind of watch and wait, and to see if the weight comes back up to its previous level. Now, we only looked at patients in whom that didn't take place. So that was quite alarming, and we did find 5 malignancies among people with unintentional weight loss. I think our total number was 230 over the course of a year. So quite a significant, not a huge number, but certainly a significant number as well. So Kelsey, could you perhaps talk to us a little bit about our larger demonstration project that we're planning?
Certainly. So one of the purposes of the pilot project was just to get methods down for being able to find unintentional weight loss within electronic health records. We had to come up with several different criteria that might be able to indicate unintentional weight loss, such as the 5%, the 10%. We worked to exclude patients who we already had explanations for the weight loss, such as they might be taking a medication that's known to cause weight loss. They might already have an illness such as uncontrolled diabetes. Pregnancy is an obvious cause of changes of body weight. And we also made use of free text notes to really fine tune what terms might indicate voluntary weight loss, because there are only about 1 million different dieting terms out there and exercise types, any of which might appear in a patient's chart and indicate that they're losing weight on purpose. So a lot of the purpose of the pilot study was to refine those so that we could be sure that what we found were true cases of unintentional weight loss. And now that we have our methods down, we want to repeat those search terms and criteria in a bigger sample. That will give us a couple of advantages. First of all, a bigger sample will be able to generalize a little bit more. We'll be able to look at subgroups, like, for example, unintentional weight loss is much common in older adults, particularly frail older adults. Perhaps we should be looking at it differently in them versus somebody who is young and perhaps beginning at a healthier life point. And as Dr. Rao mentioned, there's a lot of variability in what specific types of tests are ordered when unintentional weight loss is looked at. So we're going to need a much bigger sample just to really get concrete data on which tests are ordered and which ones are most useful. Our end goal is to be able to create a set of empirically based diagnostic guidelines that might be useful in, say, okay, you have a woman who's in her mid-70s, has a family history of such and such, and has lost 7% of her body weight within 6 months. What would be a good test to recommend her for now that might lead to a diagnosis as quickly and accurately as possible?
Okay, thank you, Kelsey. So I'll talk a little bit about our process as well that accompanies this. As Kelsey said, our goal is to develop a meaningful research-informed guidance for clinicians to evaluate unintentional weight loss. And the first step, because every problem we approach in the UH Advanced Center is going to follow the same protocol. We'll look at what evidence is out there. Unfortunately, we haven't found a whole lot. The second thing is a data-driven approach to identifying what practices are associated with the best outcomes. So let's say, for example, CT scans of the abdomen are being ordered all over the place on hundreds of patients with unintentional weight loss, and we find that almost none of them are useful in making decisions. Or maybe they're very useful, we don't know, basically. Or we find that certain aspects of the history and physical examination are actually very useful as well, or not so useful. So based on our analysis, we'll then present all of that information to a diagnosticians panel, which is led by Dr. Jessica Goldstein. And they will review this and make additional recommendations or comment on the practicality of recommendations based on it. And then we'll present this to an advisory board, which is not made up only of physicians and other healthcare professionals, but also patients as well. And they will weigh in on this. And of course, the eventual goal is to turn this into an alert that is meaningful. And of course, here at UH, this is not a bad time to do it since we are going through an EPIC implementation as well. So an actual meaningful research-informed level of guidance rather than just something that's based on consensus statements as well. So that hopefully is the future. Now, there's a couple of comments here. Mendy's PH, are there specific patient-reported issues, fatigue, anorexia that are consistent with UWO? Excellent question. We don't quite know yet. Our pilot study, we didn't look at symptom evaluation, specific symptoms. We will be looking at it. And are there key diagnostic criteria that are associated with differential diagnostic matters? Absolutely. That's something we are trying to develop. So this is a problem that has probably been around since human beings have walked on the planet, and yet we have no guidance for it, and it's associated with cancer. So this is a high priority, significant public health problem. The last comments I would make is is more likely to have unintentional weight loss, and Kelsey didn't have a chance to talk about this. We just have our data over the last couple of days to answer that question. It seems to be more women. We're not sure why that is the case. And it seems to be older patients, which is not surprising. And I think that there's a couple of reasons. We're not sure why it's women. And we've speculated that more women are coming in to ambulatory care in general, and maybe that's why it's being picked up and they're being weighed more often. But we did account for that. So we have a minimum number of weights that are necessary to participate in this. I don't know. That's the short answer to it. Older patients kind of makes more sense because they're more prone to the underlying causes, social isolation, depression, and malignancy as well. So that certainly makes sense as well. The one thing we have not done in significant detail is looking at yet, and we'll have some information about this, is their baseline BMI. We know that patients who are at a healthy weight, BMI under 25, and have unintentional weight loss are more likely to be recognized, perhaps because it's more dramatic for the physician to look at it. Somebody who weighs 300 pounds and goes down to 280 unintentionally, which is still alarming, might actually get feedback that's quite positive or might actually be pleased with that result, even though from prior literature, they are every bit as prone to the underlying cause of malignancy as someone who's at a healthy weight. So that's going to be a very, very fine line that we have to cross, or we've really got to thread the needle with that one in terms of developing guidance. Should someone's baseline BMI be taken into consideration? I think my goal is, for example, when a patient has lost a significant amount of weight, we all have an obligation to make some sort of inquiry. First, did you do this on purpose? Is it intentional? And if not, what's going on? Even if it is someone who has obesity, even if it's someone who, is younger, what is going on? And we're not doing that right now. So I think we've got a long, long way to go. Couple of questions out here. Dr. Hijaz, it might be also helpful to publish your EB guidelines. Yes, we are certainly planning to do that. Do you think, and Stephanie, do you think there is a clinician bias and lack of education that is because of the bias towards thinness, that any weight loss is good? It's a great point, Stephanie. I think that, with more than 2/3 of Americans having overweight or obesity, and, as a primary care physician, I run our medical obesity treatment programs, but I also practice primary care on Wednesdays. And I am so focused on other things, their blood pressure, their diabetes control, whatever other medical issues are going on. If they've lost 10, 15 pounds, I'm actually like, hey, you're right. I think that's not a bad thing. But we've got to keep in mind that at the very least, we need to ask a little bit more about it. So those are the comments I had. Kelsey, did you have any other thoughts before we open this up for discussion?
I think we've covered most of the main points quite well. And I agree, there definitely is a bias towards thinness, which is why we made such a point of making sure we were telling the difference between the intentional and unintentional weight loss. It would really be a problem if the two of them were to get confused. Absolutely.
So let's open this up for any additional questions or comments. We have about 5 minutes left, and then we can wrap up. Let me scroll through here.
This is Mary Delancey.
Hi, Mary.
Hi. So as a nurse, I just wanted to share my perspective, also some additional thoughts I had. Heart failure patients seem to be maybe some comorbidity that you maybe want to watch, since their weights kind of go up and down and fluctuate a lot. Number two is, it sounds like there's 3 components here, which is identifying the weight loss and determining whether it's intentional or not, which seems to be more of an EHR kind of thing. Then the second part is the treatment, which it sounds like you're doing clinical guideline creation for. But the third one is like what to do for watching or monitoring this over time. And that seems to be something that would be important to create a guideline for, and having patients as partners in that as a next step. Just some thoughts.
Yeah, excellent thoughts overall. So it is a multi-step process. Remember, we're starting at ground zero with this. This is a problem that is not receiving the attention it should. And I've said this before. I really want to thank Jordan Winter for turning me on to this issue as a serious issue. One approach he and I tried was actually asking patients to weigh themselves every week and to transmit their weight to a central repository. And we fear that the people wouldn't do it, but they would do it. These are all people over the age of 50. So that's one aspect of it. Now, I think you were hinting at kind of the limitations within the electronic health record and determining intentionality. So that was a real struggle, as Kelsey can tell us. Hundreds of different terms. The word treadmill we looked for, assuming that meant exercise, but most of the time when we write treadmill, we mean exercise stress test for chest pain. So we had to kind of take that out. Those were the nuances that we had to play with over the course of several months. Now, I think rather than relying on, let's look at intentionality, what we can do is raise awareness across the system that once somebody loses weight, your duty at that point, just like the blood pressure, if somebody's blood pressure is high, you'll say, hey, are you taking your medications? Or you'll recheck the blood pressure. You've got to ask about what's going on. And then, we can even have a little checkbox if people are interested in that, intentional versus unintentional dieting, exercise. And if it's unintentional, we do have to take it more seriously. But thanks for your comments, Mary. Dr. Saeed says, do you find the evidence behind the 5 to 10 weight loss convincing, or that is what we have so far as an alarming sign? Of course, great question. Depending on how you define it, you get 38% malignancy. That 5 to 10% is arbitrary. That's the problem. Nobody has done a threshold analysis to say, okay, if you lose 3%, it's not associated with a serious underlying cause, but if it's 5%, it is. That's one of the things that we want to figure out. Any additional comments? Okay, if not, thank you so much, everyone. We are taking a break next week. On December 30th, we are going to be talking about the diagnosis of urinary incontinence with Dr. David Shane, who is a urogynecologist here at University Hospitals. And I think Elizabeth Harris is going to play host that morning. Elizabeth is part of my research team as well. And she's very interested in urinary incontinence in older women, especially minority women, and is carrying out some work in that area. So please join us. Now that's not a life-threatening issue, but it's a very common one. And I look forward to seeing you all at that point. In the meantime, please enjoy the first part of the holiday season, and we'll see you in a couple of weeks. Take care.
Thank you. Happy holidays.
Thank you.